Right, Josh, are we good to get started?
Yes, go ahead, Dr. Riley.
Okay, fantastic. Well, I want to thank everyone for being here today. We are going to be doing a webinar on emerging technologies in contemporary PCI and particularly in calcium management. It is going to be a case-based discussion, so we'll have a little bit of discussion up front, go over some cases, and really kind of see where that takes us, going roughly an hour. So this is sponsored by SCAI, supported by Shockwave Medical. This is our basic agenda. Again, we've got a fantastic group of commentators and case presenters. We've got Dr. Alice Wad from Henry Ford, Dr. Megan Taggart from Columbia, and then Dr. Chris from the Brigham. So again, really leaders in the field who are going to kind of help shepherd us through this process and really help us learn how to treat these challenging lesions together as a group. Unrestricted educational grant by Shockwave did fund this, and then these are the various faculty disclosures. You can get credit. You can see the various ways you can get credit, mock, all the other words and ways that you can get credit. As you can see there, if you just go under your SCAI Learning Center, you're able to go under your courses, fill out the evaluation, and then get your various alphabet soups worth of various types of things. So I'm going to stop sharing my screen. We'll just kind of go here to the round table. I do just want to kind of get things started. You know, it's really interesting. When I started sort of my journey in complex PCI roughly a decade ago, calcium is something that I guess we talked about. I mean, sometimes, you know, it was like, well, yeah, you know, I had to rotablate through the extra plaque space, you know, is that okay? Or we talk about, you know, this one time that I had to do a calcified left main, like, what do we do there? But, you know, we've really seen over the past couple of years, really the past 5 years, you've seen, if you know, look in PubMed, you see the number of atherectomy articles going up. You see all these webinars on calcium. So I guess the first question is why are we here? Like, why is all this hubbub around calcium? I'd love to hear kind of what everybody's thoughts on that are.
Yeah, well, I'll kick it off. Thanks for having me here, Rob. I appreciate it. You know, I think maybe over the 15 years I've been in practice, I probably had a pretty simpleton understanding of what atherectomy did when I was coming out of fellowship. I used to think it allows me to get my stuff down there. And now as we see, you know, 12% of patients in NCDR are being treated for stent failure in emerging data, a lot of that is dealing with underexpanded stents. I mean, in terms of PCI durability, calcium's become a mainstay of how we do a good job for patients. Finding it, modifying it, make stents big, and letting them live with their first stent, not having to come back with rounds of second stents and third stents, et cetera. So at least over my practice, the nuanced understanding of calcium as a bad actor toward identifying, modifying, and making stents large, hopefully to improve durability, is the way we framed it in our practice. And that's why when I get invited to things like this, I'm excited to participate.
Awesome. I love that. And I mean, as most people on the webinar know, you know, Kevin's really known quite well for sounds bad, for treating stent failure stuff.
Thank you, man.
Gosh, I feel like I have introduced you before and I've done a better
Okay.
job. But Kevin is internationally known for treating in-stent restenosis, not because he did it, but just trying to help people who have it. And so I think that really speaks volumes kind of coming from you. So I love that. Other thoughts?
I know, like, of course, Margaret is a world expert in this, but I'm gonna have my 2 cents. It's very important to optimize your PCI to get a durable results. The problem, the enemies are always hiding, and you don't see it really easy, and you always have to assume it's there. In addition to that, I have the fortune to work in different countries. Like I do go PCIs in the Middle East or in China, and it's like I was always pleasantly surprised. They don't have much calcium. So the stent gets in easy, everything gets in easy. However, I think the treatment and our patient population is advancing in age, and the type of lesions we are seeing are a lot more complex than the lesions we've seen 15 years ago or even 10 years ago. And you look at all sets of data and the patient age increasing, the complexity of the lesion increasing, and the denial for surgery is increasing because the patient are sicker and they cannot go for bypass surgery. So it becomes incumbent on the interventional cardiologist to achieve excellent results. And guess what? you cannot achieve excellent results unless you deal with calcium and you deal with the CTO to achieve complete revascularization. And a lot of those lesions also combination of all these factors, including bifurcation, stenting, calcium management, CTO management, cytobranch management, all these things together now becoming more prevalent, even in my lifetime, which is probably long for CTO CTO and complex PCI operators. But even in my lifetime, I've seen things get a lot worse. So we have to.
Yeah,
I
that increasing
completely
prevalence.
completely agree with Cal, Rob. So, I mean, I think it's really dramatic as patients are surviving longer and longer, and it becomes a norm that you're dealing with calcium rather than the unusual situation. And it now surprises me if we IVUS someone and we don't find the lesions are calcified. You know, it's become so prevalent in the patients that we treat. Become such a regular part of not just complex and CTO PCI, but just everyday PCI. And also, I've really noticed this kind of last 12, 18 months is the NSTEMI population, you know, are getting older. They've got a lot of complex disease. And as Cal said, a lot of them are turned down by the surgeons because not only have they got lots of comorbidity, but they've come in acutely, their LV's gone off, they've got renal dysfunction. So I think it's really becoming a huge part of PCI practice.
Yeah, absolutely. I mean, you see this Venn diagram of increasing prevalence because of the risk factors, increasing recognition. I think as we see intravascular imaging, I don't know if it's having its heyday yet. It's having its sort of maybe uptick the heyday. I mean, we hope it's going to have its heyday here sometime soon. And then you see this other sort of overlapping circle with increasing sort of devices used to treat it. And I really think all of those things coming together at the right time have really led to a lot of people saying, well, how do we do this well? You know, and I think that's why, you know, from SCAI's standpoint, you know, it's been really important to kind of get this out there just in terms of disease recognition, therapeutic recognition. And that's why we have this document coming out at the beginning of 2024 on guidelines for managing calcium, which I think will be a big deal, which hopefully we'll be doing some more webinars on. And so I think one of the things that you guys kind of all brought up is, okay, we're seeing it more, and there's all these different kinds. Like there's nodular, there's long, diffuse, there's concentric, there's eccentric, there's all this stuff. And are all the treatments the same? Are they not? And I think that's where this document sort of will get into that. And I think that's where these case presentations can really illustrate the different types of calcium and different ways to treat it. So I'm really excited to jump into that with you guys. And that is me creating my own segue, which I feel really, really good about into Cal's first talk here on nodular calcium. So Cal, if you don't mind sharing your screen, we'll jump off.
Please unmute.
Okay, so I'm going to share my screen with you guys. I was speaking, and let me see here, screen 2. All right. Is my screen on a
Yes, looks good. Thank you.
Perfect. All right. So complex coronary nodular lesion, a case in calcium modification. So I know the webinar is actually sponsored by Shockwave, but I always like to be a little bit outside the norm, and I'm kind of broke the rule. You might not see Shockwave in my case anyway. So these are my disclosures, and we're going to jump and dive immediately in the case. And this is a patient actually came last week, 61 years old, 2 syncope. He has life vest. The left vest shocked him twice. EF 27%. He is symptomatic. He had symptomatic runs of polymorphic VT on amiodarone drip and moderate to severe MR. Transferred to our hospital for consideration of bypass surgery and mitral valve regurgitation treatment during the bypass surgery. So I'm gonna basically, obviously, he has a 3-vessel coronary artery disease. He's not really that old. He's 61. And if you notice, there are a lot of clips in here, and the clips here will I'm gonna tell you about why this is, and this is RCA CTO. This is the angiogram was sent to us. The RCA is filling via collaterals. The circ has significant lesion here. The NLED has significant lesion here. And a lot of people basically will kind of move on, sorry, and the surgeon, the interventional cardiologist did a picture for this nice picture for showing the lima or the subclavian. We never used to do that in the past, but nowadays a lot of people have seen it being done because previously you just measuring the blood pressure. And of course, he came in the center where he went, where he had that surgeon said no. In our center, the surgeon said no. And the reason is this unfortunate gentleman had a very major motor vehicle accident about 15 years ago. He's paraplegic and lost both lower extremity, both below. In fact, he has disarticulation of his right hip. So he has no veins to use in a bypass surgery. In addition to that, he was a smoker, and there are a lot of other health issues, including advanced diabetes. So he was actually having polymorphic VTACs. So heart team, we decided to go ahead and take him to the cath lab to kind of offer him therapy. And now this is a young gentleman, and you will start thinking, okay, so what the challenges is going to be here. I never thought the challenge is going to be the first one here on the left. He does not have femoral head, if you notice here, and the artery was completely occluded. So basically, with an EF 27% and a 3-vessel disease, including CTO on the left, I was worried at this stage about having to use mechanical circuitry support, but guess what? We don't have access for mechanical circuitry support. I think the patient was hemodynamically stable. We did right heart catheterization. His cardiac output was good. His cardiac index was good. So we decided to proceed in a strategy of basically complex disease management, but in the same time taking in consideration that we need to move fast and not cause so much ischemia. So basically, this is what we needed to do. And of course, the H-French sheath wouldn't even go through this. So I have to do balloon tracking, balloon the iliac artery, and also do balloon tracking through the iliac artery. And I was able to deliver the sheath 45/8. And sorry, I kind of jumped to. So here we wired the left circumflex, and we have to balloon the lesion because we cannot deliver the IVUS, and this is the IVUS going in. So I want you to watch this. This is, remember, this left circumflex did not really look that terrible by angiography, and that's one of the first things you have to realize when you are doing angiography. Even if you don't see calcium, 70% of the time there is calcium. And if you see calcium, almost always you underestimate how bad is the calcium. This artery here, I want to show you a really very kind of significant finding we found. This is here about, we already ballooned it, so we have about like 180, about 200, 250 degree of calcium. This is kind of here, the calcium is ruptured here. So that actually gave me good. But the other thing which I noticed, like the calcium was not uniform. So if you see here, there is not much calcium, but if you see here, there is nodule. And here in the proximal left circumflex, this is very, very nodular calcium. So the good thing, like about nodular calcium, that it does not give you 270, but guess what? We do not know actually what to do with nodular calcium. And honestly, nodular calcium is even worse. When you see nodular calcium, there are two kinds of nodules. There are eruptive and non-eruptive. And device-oriented outcome and lesion failure is a lot higher when you have nodular calcium. So honestly, we don't know what to do with it. So because of that, I tried to kind of do the fast and dirty thing. So I used a Scoreflex balloon and I dilated with the balloon several times here, two ballooning. And this is a Scoreflex is easier to deliver through calcium and expanded. This is a 3.0 by 20 Scoreflex balloon and expanded will. So basically, this is how the eruptive and non-eruptive nodular calcium. If you notice, always in the proximal of the vessel, ostium to proximal, most of the nodules happen there in the left circumflex. In the RCA, normally in the middle segment. And this is very prevalent when you have when you do ACS patient. 7% of the causes of ACS is actually nodular calcium, and it's very prevalent is 30% per patient. So what we did here, we put one stent and we put a second stent all the way to the ostium here, post-dilated. And now what that calcium going to do to the stent? And this is very, very important, important to know. This is basically, it looks really good in these results because we actually used some form of ablation. We went to high pressure, 20 atmospheres with each, but look here, the stent looks like a D shape. And this is actually one of the nodule. Here, the ostial circuit, this is one of the nodule. That nodule, remember I show you, that nodule, this is it here. And I can actually go back and show it to you. This is here. I stented all the way to the ostial circuit. This is nodule, is basically here. It's the same thing. So that nodule could protrude through the stent and actually could fail through it. So we did it, this picture, and then we turned our attention to the LAD. If you notice here, this is a diffuse calcium. And the thing which is I notice that the calcium is only in one side of the vessel. It's not on both sides. And we did a ballooning. If you look here, the balloon basically did not expand. Similar situation. I had to wire the diagonal and did a kissing ballooning and then IVUS. And if you notice this time, there is no calcium here and there's a lot of calcium in one direction. No calcium here, a lot of calcium in one direction. No calcium and here. So it looks like a slit and the rest of it is calcified. So what to do about this? We are actually, I did another Scoreflex. I said, I don't know. I don't want the stent to be not deployed well. I was thinking shockwave, and I need to hear from you, Rob, if shockwave is still as expensive and not reimbursed the same way when it first started, but I heard that change. So probably that we'll talk about it later. So even after a Scoreflex, basically, if you notice, the nodule didn't change. It's the same, still almost the same. There is nothing different in the nodule. But did that cause me to actually to change the strategy? I don't really know what other strategy I can use in this. And so we did put stents because we thought the balloon expanded well, and these are basically the stent in the mid to prox LAD, another stent in prox LAD. I take a picture just to make sure that I did not really gel the circ. And then you IVUS it, same exact thing. We have the nodule here, but the nodule here and the nodule here, and the same thing, it deformed the stent. So what to do about this? I will be really interested in kind of knowing what the panelists will think about this, and should I have done something differently? Should I have done ablation, orbital atherectomy, rod ablation, or shockwave, or even different kind of cutting balloon that have more element that cut, so I can make sure I cut all the element, and does that work? Honestly, I don't know if any of those things work for the nodular calcium. And this is kind of one of the things I talked about already, that outcome in no calcified nodule, patient fare a lot better and they do better. So when you have a calcium, you're literally stuck between the rock and the hard place. And more importantly, your patient stuck between the rock and the hard place. And if you notice, I know it's probably not the subject of this webinar, but IVUS OCT is most important. In fact, we did not know to diagnose calcium and what the forms and several shapes and different shapes of calcium before IVUS and OCT. Even nodular calcium was actually discovered after we started using IVUS. Nobody knew about it. Actually, they thought the first 3 cases described by Gary Mintz, they thought it's actually clot in a vessel, and when they did the IVUS, they discovered it's calcium. Calcium ablative therapy outcome is not really known yet in the nodular calcium, and the jury's still out on what to do in these things. And I'm really interested in knowing from the faculty what you guys think I should have done differently. Thank you so much. I'm
Fantastic.
gonna stop sharing.
Yeah. Yeah, you shared a lot. We don't want you to overshare. That's definitely something we want to avoid on this platform. So first, thank you so much, Cal. I mean, it's just I think for me, it's always I learned so much from all 3 of the folks who are on here. They've really been folks I've looked up to for a long time. So it's really fun to sit back and continue to kind of watch you guys. And I just realized that the chat you sent, Margaret, about are we going to discuss in between versus you go straight through was actually referencing what I'm doing right now. So we're just pivoting and everything's going fine. We'll figure this out later. Cal, real quick, just a quick discussion with everybody before Margaret gets going. In terms of nodular calcium, what does everybody think? I mean, big deal, not a big deal? Do we need this section? Could we have maybe done something else? What do you guys think?
I think the brilliant case, Cal, from the beginning, from the access onwards. I think a few things. One, I think it shows, and this is also true in the case I'm going to show you, is that when you see a nodule somewhere in the circulation, you're probably going to find somewhere else. I think that's quite an interesting observation, that it seems to be that some patients are predisposed to nodular development. I don't know if everybody else feels that. I mean, that's not based on any fact, just on experience. And I agree. I think, several of the technologies we have available are potentially therapeutic for nodular calcium, but we still don't absolutely know what's best to use when. And I'd be interested to hear what the rest of you feel about that in the context of some recent data we have available.
Yeah, I mean, I think to build on that, Kevin's really critical role in the Light Lab. I mean, he's analyzed a lot of vessels and looked at a lot of things. So maybe, Kevin, you could speak to this idea of nodular calcium in terms of prevalence. Where does it show up? How does it impact us? Things like that based on your experience.
Yeah, a couple things. I think Colin made a strong plea for the fact that a lot of times you don't see these things, any of the calcified signatures that allow you to change your practice on the angiogram alone. And therein lies some of the value proposition to image guided PCI with IVUS or OCT. We looked specifically at that question in Light Lab. For people that aren't familiar with it, it's a really simple design. It's an OCT observational study with 40 doctors, 12 hospitals. And the first phase of it, you said, hey, based on the angiogram, you're going to commit to how you do the case. Then you'll do a pre-PCI OCT and see what the OCT shows you. And then we just studied how people changed their case planning. The lesion composition changed about 40% of the time. And in cases where the physicians found calcium on the OCT but didn't find it on the angiogram, which is a lot, as Cal alluded to, the change in vessel prep strategy changed about 47% of the time, obviously with escalation in response to calcium. So, you're kind of putting your head in the sand if you don't think it's there, and we've got better tools to find it now. We know that calcium modification is the path toward better MSA and better stent patency. I've heard it said by Kiko, Mara, and Gary Mintz, and Margaret, you can corroborate this. I think somewhere like 2 to 5% of cases have nodules in sort of an all-comer, if I'm remembering that correctly, Margaret. But if you have a chip practice like the 4 of us do, it's way more prevalent in that, just by the types of patients that get referred to us. So I think the lower limit is in everyday unselected angiograms. You may find these things 4% of the time, but we tend to find them often. And I echo Margaret's comment. I'll show you a case of a person that had nodules everywhere in both arterial systems. And so it tends to be people collect these as a matter of unfortunate circumstance. And, if you find it in the right, you'll often find it in the circumflex too.
That's
and
true.
with regard to the best modification strategy, I won't belabor this, but the outcomes that are at least historically looked at for rota patients with orbital don't do nearly as well as rota patients rota patients with nodules don't do well as rota patients without nodules. And so at least in Disrupt CAD3, which was the shockwave registration trial, the nodular patients tended to do pretty well at a short time period, I think of 1 or 2 years. And so, there may be a value proposition to shockwave because it works differently than rota. Rota has to touch the nodule to modify it. So if your wire bias isn't there, you're not getting anything. And orbital is useful. Orbital will shave the top of it, but by different mechanisms of action, shockwave does have the potential to modify the foundational base of these things, and it tends to lead to relatively, favorable stent geometries. But Kyle, like you showed very nicely, I'll say to our fellows, we're going to commit to a strategy. I think I'm done with my scoring balloon, but you check your work, right? And if you get it wrong, you learn for the next time. And so that's where the rubber meets the road in terms of honesty of using image-guided PCI to understand the value proposition of everything you applied to the lesion to understand if you did a good job. And the MSAs in your cases looked wonderful. Geometry was off a little bit, but that sometimes is difficult to do differently with nodules, even if you throw the kitchen sink at it.
So what do you think, guys, about the strategy of I like an incremental. I don't like to think like use the biggest gun. If I can get away with using a scoring balloon, I normally, in fact, I start with the regular balloon. And of course, it's very important to IVUS it. And one of the also I see with the regular balloon expansion and how to react. And what do you think about a strategy of using scoring balloon? And if you don't get a good results, and what the criteria to call it not good results to use a shockwave after that?
Yeah, I mean, it's a great question. I think just to reiterate a few things. One, the prevalence of nodules is low, but I think the ramifications is pretty significant. I think all of us have seen, one of the challenges, particularly with eruptive nodules, is you'll treat it, right? You'll get this great MSA, you'll feel really good about your life, and then 6 months later, they'll come back and the nodule will re-erupted right into your stent, really creating a problem right where you delivered therapy. And so I think nodules are still one of the great unknowns. We have a lot to learn about nodules. I think, especially for those of us that run practices with bigger prevalences, as Kevin, sort of alluded to, it's a big deal. Sometimes I wonder if maybe the higher prevalence of nodules in the proximal circumflex might be why left main bifurcation stenting still loses to CABG. Again, unknown, but something to think about. In terms of treatment strategies, there have been several studies that have looked at this in the past 5 years, and unfortunately, the increased MACE rate in those with nodules compared to without is not attenuated by atherectomy. But unfortunately, atherectomy alone does not appear to adequately treat nodules. Again, these are smaller series, but they have all come up with the same sort of data points in that regard. Also mentioned was a small sub-study of Disrupt CAD3 looking at the use of shockwave in these lesions. There was no difference in the MSA in those with and without nodules when shockwave was used. Does that translate to long-term outcomes? Well, we think it probably does because MSA has always been the biggest predictor. But again, hypothesis generating at this point, but really important to Kevin's point, if we have a technology that doesn't move the needle versus one that has shown some promise and some influence to potentially move the needle, I think that that's important. I still think that there is a possibility that shave and shock might be the way to go to potentially take the top off with atherectomy and then really get at the base with IVL. Again, it's a little bit unclear, but I think this is still very much an area where we're actively looking at a lot of things. I think the one challenge with specialty balloons with nodules is like any other calcium. Nodules typically have big arcs of calcium associated with them. The vast majority have 270 or greater, but not all of them, right? You showed some really good examples in yours, Cal. And the challenge with like a nodule like yours is that balloon's going to expand away. It's going to go towards the more compliant area as opposed to that really calcified area that has very low compliance. And so that can be a real challenge because you're going to deliver all your scoring or cutting or whatever verbiage you want to use really towards that more compliant area. And so are you necessarily treating that calcified area? Unclear mechanism of action might say possibly not, but again, it's unclear. And then what are you looking for? That was the last question that was brought up, is like, well, my stent looks a little weird. It's a little kidney shaped, like it's got this nodule still behind it. The one thing we know is that, when we started imaging, when we were doing CTOs, right, we do these long subintimal sections. Because when I started doing CTOs, we weren't imaging, which I'll say softly, but we were imaging a lot more, over the past 5 or 6 years. We start doing these long subintimal extraplaque spaces, and the stent would look really weird. it'd be like this kidney thing, and we'd all looked at it and we were like, is this okay? Like, what is this? And we started to look at the long-term outcomes, and it was like, okay, so they have really similar rates to intraflat crossing. So what's the deal with that? And it turns out it's not necessarily the shape, like we've always known. It's not necessarily even apposition per se. Lumion even told us a little bit of that potentially, but it's more the MSA, right? Like we have all these variables that we look at, but at the end of the day, it's hard to beat MSA as a predictor for how someone's going to do. So really good discussion. We could go for a long time, but I want to keep us a little bit, on time here as best we can. So I'm going to let Margaret kind of get going with a case on managing long diffuse coronary artery disease.
Thanks, Rob. Great discussion. So this is a case I did recently in New York. It's a 74-year-old woman who, much like our discussion at the beginning, she presented to an outside hospital with an NSTEMI, and she really had quite bad acute pulmonary edema, requiring her to be intubated, and she had AKI as well. It's quite a large lady with a BMI of 40, she's diabetic, COPD, AF, and really one of her biggest problems comorbidly was that she really had very severe anxiety, almost, healthcare avoiding level anxiety. So of course this was her coronaries. So she had calcified distal left main bifurcation, further calcified disease down through that circumflex, quite diffuse down to that more distal limb where it was really quite tight at the bifurcation. And then she also had quite severe calcific disease diffusely through the LAD and diagonal. And then she had disappearance here in the right coronary artery with this calcium at the ostium, and then calcific disease all the way down to the distal vessel. And actually, on closer inspection here, the ostium really was quite critical. And my suspicion here was that this was probably a nodule. So her EF recovered to 50% over the days after her admission, and her creatinine actually recovered to 0.9. She was transferred to us for surgical review and for revascularization. So the surgeon saw her and felt she wasn't suitable for bypass surgery for all the comorbid reasons listed, but largely because she was refusing it, and they were really concerned about her ability to rehabilitate and her ability even to cope with the perioperative period of her care. So actually what happened, so I decided what I would do is I'd tackle the right first and then deal with the left system. So actually when we engaged, it was very difficult to engage the right, and when we engaged it, I was able to wire, but I actually managed to get 2 microcatheters stuck in the ostium to the point that I was concerned I wasn't going to be able to retrieve them. That was how tight the ostium was. And eventually I managed to get one of the microcatheters in and free wire with the rotowire, and took a 1.5 bar and rotaway down through the osteoproximal vessel. And you'll see the IVUS on the right-hand side then shows us what we find. So there's segments of the vessel from the mid to proximal right where there's concentric calcium, the segments where the calcium is eccentric, and once we get to the ostium, you'll see there's a really carved out, shaved cap of the nodule that was at the ostium. So kind of combination morphology, but certainly keeping with the clinical behavior, the severe nodule at the ostium. So I then went on and used a series of non-compliant balloons, and then with a guide extension was able to stent from that distal landing zone all the way back to the ostium, and got pretty decent stent expansion with that strategy. And this was the final result on the right coronary artery. So I think, critical uncrossable lesion, nodule at the ostium, I think in this case, atherectomy for her was the right therapeutic intervention. And actually, Akiko's gone and looked at all our right coronary osteal lesions, and says that there's a nodule in the ostium of the right in over 50% of the cases. So it's helpful information, I suppose, to know when you tackle these cases. So actually, we staged her to come back for the left system a couple of weeks later, and she went into the Empower study. We can talk about that a little bit if we have time. So the plan was to deal with the left system with a combination of balloon-based technology and shockwave. So actually the LED responded quite effectively just to non-compliant balloons, And you see the IVUS on the right, that as we come up, there is concentric calcium, but quite a lot of it, there's reverberation, suggesting that the calcium may be thinner rather than thicker. And actually, we're able to get decent fracture and modification and luminal gain just with non-compliant balloons through the proximal to mid-LED. And I went on to stent the mid-LED and then wired the diagonal and treated that lesion in the diagonal and then stented across to the proximal LED, and angiographically, at least at this point, feeling like we had pretty good stent expansion. So went on to treat the circumflex. So this is the IVUS of the circumflex. You'll see again, there's segments of concentric calcium, but as we come to the ostium, you'll see in the bottom right-hand corner, there's a nodule and the distal left main into osteal circumflex, as we very frequently see in these cases. So you see the LED wire coming in from the top and this nodule down on the right-hand side protruding. So the target in the Empower study for the IVL here was the left main and circumflex. So we go on and treat the left main and circumflex with shockwave back into the left main, and it really expands angiographically really well. And then we repeated our IVUS, and you'll see here as we come to the ostium that we seem to have pretty good modification of the nodule from the IVL. So I was happy at this point that we'd modified it adequately. It was really kind of flattened the nodular protrusion. So I was happy at this point to go on and treat. And my strategy was, I'm going to treat the circ back to left main, and I'm going to use, you see the nodule there, it's completely modified, the shape of it is kind of shattered. So my strategy here was, I'm going to stent circ back to left main, and I've got Colot as a bailout strategy. I've secured the proximal to mid-LED, but I might not have to treat the ostium of the LED, let's see. So we stent back into left main, do a pot, I rewire the LED, and I decide I'm going to IVUS both limbs, and this is what you see here. So in fact, really interestingly, we've seen this now in 3 or 4 cases. The IVL has modified the nodule favorably away from the LED, right? So we get a nice stent expansion in the circ, but actually when you see the IVUS pull back from the LED, you see that actually the ostium of the LED, the MLA has increased following the IVL rather than reduced from stenting across it. So we've had favourable modification of the nodule away from the LED. And we're really pleased with this. So we decided we didn't really need to convert to clot. And you see the right-hand side, that's the ostium of the LED there. And when we compared pre and post, we'd actually increased the MLA at the ostium of the LED with the IVL from the left main into circumflex. And here's the still images. So on the left, that's the MSA, the carina and the circ, and the one on the right was the ostium of the LED, both really encouraging. And here's the final angiograms of the left system. So nice outcome, both in LED diag, left main and circumflex. So I think what this case, I suppose, illustrates to me is that we can deal with diffuse calcium in multiple ways. I suppose historically we've always talked about dealing with it with atherectomy more than balloon-based technology. But I think this case to me was quite interesting because we used 2 different strategies for fairly similar morphology in the left system and the right system, although obviously the ostium of the right was uncrossable at the start. And we ended up getting, nice targeted MSCs and all the lesions. I'd be interested to hear your guys' thoughts on that.
Yeah, well, that was fantastic, Margaret. Thank you so much for sharing just just a routine Monday case for you, and I think, but for so many of us, so much to unpack and learn from that. I do think even when IVL came out, the kind of the company, everybody's sort of thought was, hey, but if it's really long, we got sitting on 80, 100 millimeters of lesion here, like this is really where atherectomy is still going to be quite important, because we were still figuring out how to deliver the device, where do we use it, all these things. And then came this idea of kind of pulse management, right? Well, we will run our imaging catheter down, and it turns out if you've got a really long lesion, not everywhere actually needs calcium therapy, one, and you often have these mixed morphologies, sort of as you brought up. You're often going to have some nodular, maybe some eccentric, maybe some more concentric, and let's use our IVL in the places really where that's going to make the most sense. Now, sort of as we've learned to use it more, we figured out, oh, actually it's pretty deliverable. Sometimes you just need a guide extension or a buddy wire, and now even more so that the company listened to the feedback of, hey, we need similar pulses, we've had the C2 plus catheter, which has really allowed us to tackle some of these longer lesions. Whereas before we're like, man, am I going to use 2 catheters? What does that mean financially? Like, I'm not really sure, and all these stuff. Now we really have the ability to treat these longer lesions with that. So I think it's continuing to change, as the technology changes our treatment approach. I'd love to hear sort of everyone else's thoughts on treating sort of longer, more diffuse calcified lesions.
So I frequently found that it's basically you only end up with the 1 or 2 spots that actually not responding. So long calcified lesion does not scare me anymore, and I don't think it's a by default it's a root ablation or a CSI case. In fact, long calcified lesion, if you root ablate or orbital, you actually probably run higher risk of distal embolization. And because you have a very larger plaque burden and kind of anecdotally have been burned before. So I think it's actually make a perfect sense to use other ablative strategies that you can actually spot treat it and direct it toward. And of course, you need imaging for these things. But it's kind of amazing to me, and I'm very happy to see this, that the ostial circ, as you know, this is the pain in our side. That always, when you are dealing with the bifurcation of the left main, the ostial circ, the highest failure, the least to expand. And this is fascinating, Margaret, what you presented. That's really, really amazing.
We've had 3 or 4 cases recently where we've seen this, where there's been that very typical nodular appearance, the distal left main on the kind of inner curvature of the circ. And we've shockwaved it, and then we've IVUS both limbs again, and we've had a Kegel look at it, and specifically look at what it does to the. So it's quite interesting. I think. I think there will be certain morphologies in the left main bifurcation, where that'll be the case. And I think we even had one where the nodule was actually left main LED, which is, I suppose, the less common morphology we see on the same thing. So I think we need to look into that in a wee bit more detail, I think.
Absolutely. You brought up Empower, and gosh, having the opportunity to have you sort of be able to speak about that, Margaret, I mean, it's a rare opportunity to get, a national PI to be able to talk about their study. So I think spending a few minutes just talking about that and how important that study is would be really beneficial, if you don't mind.
Yeah, thanks, Rob. So essentially, the idea behind Empower was that in the Disrupt trials, a small proportion, as in a lot of the coronary trials, of the patients were women. And Shockwave were keen to try and kind of, I suppose, level the evidence base. So they came to us saying, if we can do a single arm trial and recruit 400 women, it'll level the data between male and female patients on the use of IVL. So we designed this trial. We decided that we were going to try and design it as a real all-comers trial. So essentially, the only thing that excludes you, well, you have to be a woman, but the only other thing that excludes you is you can't be in shock, and you can't have ISR. But everything else gets in. So STEMIs, end STEMIs, multiple lesions, left mains, everything. And actually, it's really interesting because the cohort certainly we've recruited so far at Columbia has been patients like this. So I think already we've put like 4 or 5 left main cases in. So I think all those patients that don't usually get into trials, 85, multiple comorbidities, LV dysfunction, they're all going to go into the trials. So it's going to be a really rich data set of calcium management, not just for women, but also for the whole kind of calcium population. So it's going to be really intriguing to see what we show. But the idea of the trial is essentially to show that Shockwaves is as efficacious for female patients, but also to support the signal that came from the Disrupt sub-analysis that showed that it looks like IVL is as safe in women as it is in men, which is obviously counter to the observational data from the atherectomy trials for both orbital and rota that shows that atherectomy is associated with more complications in women than in men. So if we truly have a therapy that doesn't hold that increased risk, then that would be great.
Yeah, I think, we have so many steps in terms of leveling the playing field for men versus women in cardiac disease in general, certainly in coronary disease, and in particular from our percutaneous and surgical treatments for that matter. And I really hope that this is a big step sort of towards many, a part of many steps to get there. But I think a lot of us are really excited to see that. For the sake of time, I think we're going to transition to Kevin, if that's okay, who's going to talk to us about eccentric calcium.
Thanks, Rob. Can you see my slides okay?
We can indeed.
Great, thank you. So to Margaret's point earlier, this is a lovely lady I've treated a while back now who had nodules in lots of different places. She had class 3 angina on 3 antiangles, was eventually referred to us from an outside hospital for multi-vessel PCI. These are the outside hospital films. Decent amount of calcium, a little bit of tortuosity, right, Rob?
A little bit.
Yep. And this is her circumflex and left system. Later in time, we figured out that the nodule in the ostial LED was not flow limiting with a negative physiology study. So having exonerated that, the target's going to be this circumflex eventually, and first the right coronary artery that I showed you. So maybe, just for a nod to what Rob talked about before, this is the SCAI expert consensus statement on the management of calcified lesions. This is the flow chart that several colleagues, about 20 of us, put together with a lot of time. And the main thing is that, whether you can get a balloon across ends up being in some part illustrative of what you're going to do, but there really is a call to action to use intravascular imaging to understand this. And so, unfortunately, at least in Massachusetts, I'm not sure about other states, a lot of centers that don't have surgery on site don't have access to mechanical atherectomy. And so I think for calcium modification, Shockwave is going to be transformative for these centers because until now, they really didn't have anything. But this particular site doesn't have rotor orbital, and sometimes you do need that in certain cases. And so this case was tried 6 French radial, a reasonably supportive guide, but not too surprisingly, they failed to cross despite having a guide extender in place. And so luckily, the artery didn't dissect, which is kind of the hazard of when this happens. At that point, you really need to just buzz it and get after it. But patient did fine, was discharged, and was referred to us. And so we went ahead and took a lot more of an aggressive strategy with regard to backup. Having seen our colleagues struggle, we went with an 8 French system. I tend to do a lot of complex radial PCI, but at some point in time, there's nothing better than an 8 French 45 arrow in the thoraco-abdominal aorta in a supportive guide. And so with this in mind, sort of I'll leave it to Rob, Kyle, or Margaret in terms of what you do from a first strategy here, how you deal with this thing, et cetera.
Amazing, amazing case. So you already have guide extension also in addition to the guide, or am I just imagining this?
Yeah, no, we ended up putting up a guide extension because we knew we were going to need one. So it's probably an AL 0.75, a guide extender. And this is a little beaten up from the prior iteration. So it was tough to wire. I probably was on my 3rd wiring. And lesions like this, are a little bit terrifying because I'd almost rather deal with a CTO than something that looks disconnected like that. Because if it's a real CTO, it's got flow from the other side, the hazard's low. But I was looking at this thinking, man, I'm really likely to shut this down. And trying to get your wire to remain torqueable and not get into dissection plane here and something which had already had a couple balloons shoved to it was something that I was a little anxious about as I looked at it. And so it wasn't surprisingly difficult to wire.
Can I ask a question, Kevin?
Yep.
And I hope the audience, the faculty, I'm always like kind of torn between using the supportive rota wire, the extra support, or the floppy in these things. And I have my own ideas and biases. What do you guys do in these situations? This is really faces a lot of people.
Yeah, so we march in similar circles, and my good friend Bill Nicholson, for real bad tortuosity, he favors the extra support wire. And the point there is when the rota wire digs in and bends, it tends to kind of flex a little bit. And that's his belief that it grabs normal tissue and perforates there. That I think there maybe is something to that. That said, I use a rota extra support maybe once or twice a year. And so we typically favor the rota floppy, but I tend to use it at the burr. We don't do 150,000 RPMs. In a case like this, it starts at 180, 190, and it's going at 200 pretty quickly. And so a little bit of how you use it and how you not stall the burr may have some part of that. But I'd be interested, Margaret, do you have a certain algorithm for that, or?
I'm pretty much like you, Kevin. I tend to routinely use the floppy and only would reach for the stiff once or twice a year. So yeah, similar
Hopefully you
to you,
haven't.
mainly just because I suppose with other kind of experience and techniques and tips and tricks of how you use it, it doesn't seem to be a big issue. Would be really, I suppose. And I can understand the kind of theory behind why you might want to use the stiff, but I have to say, quite honestly, routinely, I largely just use the floppy.
Yeah, me too.
So when you primary wire like what you did in that Ostial RCA, I found the supportive easier to you wire with it, especially if it's kind of even more diffuse and longer, very pinhole when you can. Do you use the floppy even to primary wire?
Yeah, I do. And I have to say that since the Rota Drive Wire, I mean, it's really transformed your ability to do that. I mean, I've been very impressed with the upgrade in the wire technology. And, don't hesitate in the way I would have done in the past to do that because of that.
Okay. So it looks like you drilled with a 1.5 burr. Where did you go from there?
Yeah, so I think I tried a Pilot 50 and I think a Pilot 200 just kept going to places I didn't like, and as I said, I was worried about shutting it down. So this is a SCAI-TV wire. We use this to go retrograde, but the nice thing about it is it's super soft and it tends to find its way through nasty anatomy atraumatically. So eventually I got that down. I took a Mamba Flex, you can see, which is here, and switched out for a 1.5 rotaburr and did a whole bunch of burring to polish it. And then this is sort of, I titled this Holiday Calcium Potluck, because although Rob had given me eccentric shown here, there's also concentric and there's also a beautiful eruptive nodule. So, in looking ahead, you saw the patient circumflex. I think you have a sense of what we're going to find over there too. And so in some aspects of this, there are calcium fractures. So it looks like we were able to modify it appropriately, but this nodule is large. You can see the foundational base of these that makes us worried. And I think to Rob's point, this is where we believe Shockwave may have a value proposition. After a whole bunch of rota, it didn't look like this was touched at all by the burr, probably because of the lack of wire bias toward it. And so at this point, I'm looking at, not a whole ton of fractures through multiple concentric segments in a big nodule. We decided to apply IVL to this. I mean, a delivery was relatively straightforward. The one thing the IVL has done is it's lessened my personal use of 175 and 2.0 burrs. I often will rota, shock, or shaved and then get a pilot hole to add IVL to the larger segments. And many times I'll take just a long balloon before I even do this just to see where the points of constraint are. You can see here, initially the IVL didn't release, but eventually we were able to get balloons down, good expansion. And this is the final angiogram after stenting and post-dilation. And to Rob's point earlier, many times these nodules will look like a kidney bean, as seen here. I kind of pulled this out from the IVUS run that's going to go by. But I was pretty pleased throughout all segments of what's relatively noxious anatomy. We got very good minimal stent areas through this. And there is a little bit of an sort of an oval shape to the stent. But considering the nodule I started with, I was really pleased, because sometimes if you don't modify these appropriately, they look much worse. Thoughts on that, or should we move on to the circumflex, Robert?
Well, I think what. Oh, so sorry. Go ahead, Margaret.
Sorry, Rob. I was just going to say, brilliant tip there, Kevin, about using the NC to locate where to use your IVL. Yeah. So go up and down the vessel with the NC and look where it's constrained. And then, I mean, not such an issue now. We have 120 pulses, but when we had 80, I suppose more of an issue, but very helpful to target it, because even when you're dealing with a nodule, you're going to need to give quite a lot of therapy to that location. You don't want to waste it in segments of the vessel where you don't need it. So I think that's a great tip for people watching.
Yeah, I'll usually take a 30 or at least a 20 down and sort of see where the wastes are and then focus stuff there.
Yeah.
Kevin, did you shock the ostium of that RCA? Because to me, it looks really heavily calcified, or did you need to do that?
Yep. We did pulses throughout this entire segment, try to sort of do what Margaret was talking about in terms of pulse management. One of the things I'd be interested in the faculty's thoughts, but nodules tend to take a lot of pulses. So I concentrated a bunch on that nodule and then did, serial dilations with 20 or 30 through this whole segment. And I think you can see here, again, the imaging keeps us honest, Kyle. Let's see how I did at the ostium in terms of stent expansion. Looks like it gets to the guide right there. So I didn't get out to it. Yeah, it's pretty big though there, see? Before I get into the guideliner.
Yeah. So, so I
Very
want to
good.
give us a little bit of a platform just because we've got about 5 minutes remaining. I think a couple of things with just the RCA that come to mind for me are one, again, just going back over the heterogeneous nature of calcium, all the different types, and how different technologies are really helpful for the different types. I think that the cases like this used to give me a little bit of reflux because I would hear, I'd probably hear from an administrator, "Hey, did you know that Kevin was bringing this same patient back multiple times for shockwave? Did you know that? And did how is that affecting sort of everything? Because being cath lab director these days is very different than it was 10 years ago. Like the stuff, the headaches now are like really different. And so I do think that the new, payment, the DRGs that came out for inpatients for Shockwave as of October 1, where you're getting roughly an $8,000, payment for doing Shockwave that more than covers the device is really, it's thankfully helped me shake that monkey off my back. And people can talk about whether it's right or not to talk about how much it costs to treat patients, which is totally a different webinar. But unfortunately, it's the world we live in. And so I think that has been really positive. And I think the TPT, transitional pass-through payment for outpatients, that's hopefully going to transition over to a very similar payment schema for our outpatients next year is going to be really positive. I guess that was a big thing I thought here as you talk about moving to the CERC was in the past this would have been something I would have probably had to hear about and had to navigate. And I'm glad that's going away, and I'm glad that we're going to start getting RVUs for our time. Frankly, the 2.97 or whatever it is, that's going to start in January 1 is really, really positive. But Kevin, do you mind taking us kind of to the CERC and kind of keeping this going? We got about 3 minutes, so let's see what you did here.
Quickly. So these are the outside hospital referral films. These are my setup shots for it. And you can see, I think we expect that there is going to be more nodular calcium in this person. And so one of the nice value propositions to Shockwave is I like to use it if I can get it there in cases which are, super torturous with regard to being prone to atherectomy complications. Here, the segment where the nodules are is not that tortuous, but right afterwards, it gets really bendy, and you can see what my wire had to do. So in this particular case, let me see if I can use an IVL up front strategy. Pre-dilated, we did this 7 French radial, so this did not necessitate the same big gun access that the right needed. Pre-dilation, not surprising, there's a decent divot in the balloon. We went ahead and did OCT. The OCT started to get a little hard to deliver distal, but at least pre, I could get an image of it. Not surprisingly, this is what it looks like as it plays back. And here you can see there's another eruptive nodule in this patient, in addition to both some concentric and eccentric calcium. But the OCT co-registered pullback is right here, so you kind of see where the images are coming from. And she had really big and extensive nodules in multiple segments. And so, to be able to touch that nodule, you're either dependent on wire bias or a whole lot of motion of your orbital. And so potentially the sizing of IVL to 1-to-1 might help here. And so we took an IVL strategy. This is a constricted IVL balloon. This is after a whole bunch of pulses. It looked better. We went ahead, stented it, and post-dilated it. I tend to like to use high radial strength stents here, so you can kind of see the darkness of the metal. I'm sure you can guess what that is. And then we were unable to get the OCT down all the way into the stent because after I straightened some of this, the bleeding propagated a little bit. But we got the OCT in enough that we were able to see that I had a whole bunch of proximal malapposition that we addressed with a 1-to-1 size 8mm balloon just to fix that. And then you can see the final angiograms here. And so I chose this case because it's a lot of nodules, which Margaret alluded to. You tend to collect in patients that sort of form these things. And one was a rota shock and the other was a primary shockwave approach. And I think the anatomy and the size of a pilot space to get them in allowed me to use one strategy in the right and a simpler strategy in the left. So that's it, Rob. And again, I appreciate the invite. Glad to be here tonight.
Absolutely. Yeah, I think, it's so interesting taking on cases like this when I started this, where it's like, oh, you got to be 8 French because we got a 2.0 burr or we got whatever else. We want to make sure we get it down. And I remember doing we were lucky enough to do the first case after FDA approval. And, we went 7 French radial and we didn't even have to go 7 French, right? Because we needed to shock. It was a wire across the won't go. We needed to rota up front and then deliver the IVL. And being able to go radial with 6s and 7s. I mean, I still like 7 French radial. Maybe that just makes me old, but I love a 7 French radial guide. And to be able to do so many things, calcified left mains, whatever else, from a radial aspect is I hope going to get us in the US a little bit more up to speed with the rest of the world in terms of how we treat patients from a radial aspect. But really, really cool illustration of that technique there, Kevin. We're pretty much at time. I did want to address one question before we go off. Somebody asked about laser in calcium. If any of you guys want to talk quickly about that, just to make sure we get that question answered.
I like so I think calcium, it doesn't work against metal, like so it works against the bondage or the bonds between the calcium molecule. So it's gonna, God knows what's gonna work. And the laser, if you have a polymer jacketed wire, you're gonna damage the wire, and even some of the workhorse wires, you're gonna damage the wire, and the wire itself is gonna prevent you from delivering devices. So but against nodular calcium particularly, like the laser catheter only works just about 0.5 millimeter distal to what it is, right? And it's kind of heats and causes the laser bombs. I'm not sure what mechanism is going to work against. I don't know. Kevin, you use a lot laser than I do. So what do you think? Would it work against nodule?
Yeah, so most of the laser that we use is for dealing with in-stent restenosis, and Paul is alluding to laser on contrast, which is directly off-label. I qualify that, but laser on contrast really helps the laser to generate an acousto-mechanical shockwave effect. It's almost like IVL. It does it independent of a balloon, but we tend to only like to do that in native vessels. In ISR vessels, because if you do it in a native vessel, laser on contrast has a higher risk of perforation than we like. So although you could say, oh, laser on contrast generates acousto-mechanical energy just like shockwave does, all of the use of that among most of us is in stent, where you're a little bit more protected than in native lesions, because if you laser on contrast a lot, you will eventually get no reflow. And if you do it on a bend, you'll actually get perforations. And so I would much favor for native nodular lesions to be using IVL, because it feels, at least to me, safer. That said, we have a lot of experience with laser on contrast for fracturing calcium for underexpanded in-stent restenosis, and it works really well there, as does shockwave, honestly. But all these things are off label, so I'll stop talking, Rob.
Well, how about we kind of wrap up? How about just one or two kind of key takeaways from this hour we've had together? We'll start with you, Margaret.
So I think they were, I suppose, to some degree spoiled with the technology we now have available to us. I think there are pros and cons to each of the different devices, as you've heard us all discuss. I think IVL truly has been a very positively disruptive technology in the space. And I think, I suppose the cases we've shown have illustrated certain scenarios and situations in which it has helped make procedures, I suppose, more efficient and also safer for our patients. And I suppose I'll leave you with Empower. Hopefully, we're going to go on to show that, in addition to that, it's going to provide a therapy that will be equally efficacious and safe in women as in men.
I love it, Kevin.
So I think that everybody's highlighted the importance of intravascular imaging, and for acknowledged things like nodules, we don't know the right answers. But for any calcium signature I see, aspirationally, I want to do a good job. And so I'll see it on an angiogram, I'll see it on an IVUS or an OCT, I'll make a best guess of what I need to do to modify it. I'll try those tools, I'll put a stent in, I'll post-dilate it, and I'll keep myself on it. So if I don't do a good job, I can hopefully learn for the next case. And so I think the bar at the end of every calcium modification case is, what is my MSA? Did I get to the place I need to be? And if not, we hopefully learn to get better. And that's all sort of, I think, we can do for some of these scenarios where we don't know the right answer currently.
And last but certainly not least, Cal.
Thank you for inviting me, Rob. This is amazing. And as we kind of move to take care of our patients, we really have to kind of rise up to the occasion and treat them with basically for our treatment to last. So the last thing you want to do to be stuck in calcium for hours and not able to deliver the stent. So I think I just reiterate what the esteemed faculties before me said, like use your tools, be ready to move on and change your strategy. And if you can't really deliver things, there are ablative therapies you should do, either rod ablation, CSI, or rotoshock, any device. And what that requires that you need actually to be able to use these devices and learn how to do them. And most importantly, you're not going to be able to use them and know how to use them without imaging. So that's my last word.
Well, again, I just want to thank all three of you, for being here. Kevin, Cal, Margaret, people that I have learned a lot from, really looked up to over the years, people I consider to be good friends. And it's just fantastic to be able to continue to learn and educate with you all. I want to thank SCAI for putting this together. We want to thank our sponsor, Shockwave Medical. And we want to thank all of you for being here. Please go do the evaluation, get the credits for the various letter combinations that go to important things like keeping you licensed, I guess, at least for now. And so again, any questions, please feel free to reach out to any of us. And thank you all again for being here with us this evening.